My pleasure to introduce our next speaker, Dr. Anil Chandraker. Dr. Chandraker is a leader in the field. He's the past president of the American Society of Transplant. Currently, he's a professor of medicine at UMass and the chief of nephrology. And he'll be talking about early post-transplant management.
Thanks, Jamil. This is my background slide, and these are my disclosures. So today I'm going to talk about early post-transplant management of the recipient. And the way that we're going to talk about this is really, there are two objectives to this. And one is to apply a structured approach to monitoring the patient post-transplant. I think this is really important because ultimately what you are looking for in terms of graft dysfunction depends at the time point at which that graft dysfunction is occurring. In other words, immediately post-transplant, your differential diagnosis is going to be quite different than what it might be 2 weeks following transplant. And then the second thing I'm going to talk about, and the second objective, is really to talk about the individualized early kidney transplant management based on the individual risk factors of the recipient and the organ, as well as the immunosuppressive strategy, et cetera, et cetera. So, as I've already said, the key to making the diagnosis of graft dysfunction is really figuring out what is the dominant threat within that time period, early post-transplant. So if we think of the first 90 days as being early post-transplant management, you can further subdivide that time period into the first 24 hours, really the first week, then weeks 2 to 4 and months 2 to 3. There's nothing special about these time points. There's obviously a little bit of overlap with all of them, but just in broad strokes, it gives you an idea of the kinds of things that you should be looking for at different time points. So for example, early on, in the first 24 hours, you're going to be much more concerned about hemorrhaging, anatomical issues, surgical complications. In the second time period, 2 days to 7 days, you're going to think more about delayed graft function, what are the potential causes of that. And then really from weeks 2 to 4, the focus may be more on rejection, drug toxicity, adherence failures. Recurrent diseases usually you'd start to think about them at this point. Recurrent FSGS can occur very early and immediately, but often you don't think about it as a diagnosis unless you are suspecting it ahead of time. And it often is, the diagnosis is delayed if it is unsuspected. And then months 2 to 3, you're really talking about electrolyte abnormalities, post-transplant diabetes, and infectious risks. So really, if you think about the strategy of looking at what is the differential diagnosis based on time, it helps you structure your approach to investigating the patient and managing the patient more effectively. And I think critically, this is one of the things that you should think about, if you have a question in the board review, is the time is often the clue as to what the cause of the abnormality is. So for the next few slides, we're going to talk a little bit about what we would consider to be standard monitoring for the first 90 days. Now, of course, every center has a slightly different approach to this. Different centers will discharge patients at different time points. Some may do very, very fast discharges. Others may discharge patients at different time points after that. So this is really more of a consensus of what would be sort of broadly accepted. It isn't really a guideline per se, but it just really gives you an idea of the kinds of things that you should be looking at and what to expect at different time points. So, the parameters that we would think about are urine output, weight, blood pressure, and then the frequency of how often you check them depends on how far out they are from transplant. The important point is that you escalate this investigation of the patient if there's an abrupt urine output fall. So this is obviously one of the things that, when patients get discharged, you tell them if there's a sudden change in urine output, that is really something you need to report back to the center immediately. And obviously with lab testing, electrolytes and creatinine, Um, the trend is what is important. When the trend deviates from the expected trajectory, then I think you need to sort of understand what is causing that. And so remember, the normal creatinine is not the baseline creatinine. It is the best stable post-transplant value that is used as the comparator. CBC's monitoring is important for cytopenias. It also gives you a clue about bleeding, hemolysis, etc. Tacrolimus trough levels, again, important not just for making sure that the patient is adequately immunosuppressed, but also in terms of potential for graft dysfunction and neurotoxicity. Urinalysis and urine protein is important for looking for recurrent disease, particularly FSGS in the early post-transplant period. And then viral monitoring and tests of alloimmune responses are again important to think about as potential concerns, looking at different assays at different time points early on. It's more important to focus on whether there's any donor-derived infection and whether this is a particularly high-risk kidney in terms of hepatitis C or hepatitis B kidney. For example, after discharge, really we're more focused on BK and CMV monitoring, and then that will continue over time. And of course, looking for urinary tract infections in the patient. Surveillance for rejection, we'll talk a little bit about later on in the talk. So really, within the first 24 hours, the way you can think about this is that perfusion is really important to think about as an issue, and you need to do continuous hemodynamic monitoring. You need to avoid hypertension, as that can potentially cause graft dysfunction. It's important to assess the individual patients and their requirements for fluid replacement, and not just blindly do a one-to-one replacement. And of course, individualized blood pressure control. The important thing to remember here, it is the chronic baseline, and also where the donor kidney is coming from. A kidney from a hypertensive donor may not like normal blood pressure. So you have to take this into account when you're looking at what is the target blood pressure for that individual patient. Of course, drains, wounds, output are really important. Any changes in any of those may lead you to suspect that there is an issue either with a leak or an obstruction in the case of decreased urine output. And then lab and drug exposures, other than creatinine and CBC and chemistries, we have to also think about hyperkalemia as a potential cause of arrhythmias or cardiac events. And again, that needs to be monitored very carefully. Antimicrobials need to be dosed for renal function, particularly to delay graft function that's going on. And then in terms of things that you might expect to be taken care of, but may need to be checked very specifically, or what are the immunosuppression plans and prophylaxis. Make sure that you think about venous thromboembolism and glycemic plans. Often patients may get hyperglycemic following transplant because of steroids and tacrolimus, and you need to make sure that there are plans to deal with that in the individual patient. Often hyperglycemia tends to get overlooked because they may have a different provider for diabetes, and you may need to make sure that somebody from transplant center is really taking care of that. So when the patient gets discharged, remember the patient needs to be on antimicrobial prophylaxis, and the dosing of this depends not just on the individual patient, but also what is their risk stratification. So example, the CMV strategy will depend on the individual center's policy, but the donor and recipient serotyping is really important for making sure that they are adequately treated. The wounds and devices needs to be a plan for stent removal if the stent is still in place, and when the urinary catheter is still in place, that needs to be taken care of. If the patients have a hemodialysis line that is being used for access, then a plan needs to be made either to flush that or to remove that when the patient gets discharged. And these are often things that can get overlooked. So in terms of risk stratification, you need to really think about this even before you get the first creatinine back. There are recipient or surgical issues that need to be thought about. What is the risk of vascular disease? Is the patient a vascular path? Was a prior pelvic surgery that may complicate recovery of the allograft? Is the patient obese? Is that going to be a difficult patient to biopsy, for example? Anticoagulation, if that has been stopped prior to surgery, what is the plan for restarting that? In terms of recurrent disease, what do we know about the risk of recurrence? Was the diagnosis of the kidney failure known prior to transplant? Often we don't know the cause of the kidney failure, and we need to sort of remember that there may be a risk of recurrence even when we are assuming that the patient has a different cause of their renal failure, if it has not been documented by a biopsy or the patient having very strong follow-up prior to transplant. And then there are immunological risks, which previous speakers spoken about. And again, that needs to be thought about in terms of what is the risk of a patient getting rejection, and what should their immunosuppression be. And then there are all sorts of other system issues in terms of making sure the patient has coverage for immunosuppression, transportation, etc. Otherwise, the patient may not be able to get adequate coverage for the immunosuppression or be able to get to the clinic. So that just really covers a little bit about standard care. What about graft dysfunction? So in terms of thinking about what is graft dysfunction, we're really thinking about two things. One is an elevated creatinine, and the other is a low urine output. And it may be one good way of thinking about this is really thinking about what are the different causes of graft dysfunction. So there are issues that you would think about early on, such as vascular thrombosis or obstruction, a leak, hematoma, or lymphocele. There may be perfusion issues like decreased volume if the patient has diarrhea, or they have had, if they're urinating a lot and the volume has not been placed, or they have shock for other reasons, or if they have bleeding, which is causing hypertension, or maybe they have had excess ultrafiltration on dialysis. So perfusion is the other thing that needs to be thought about. And then thirdly, thinking about the kidney itself. In terms of what is going on within the kidney, is there evidence of recurrent disease? Is there infection? Is there drug toxicity? And ultimately, if it cannot be explained, then you need to proceed to a biopsy. So what are the surgical issues that you should think about? Renal artery thrombosis, that will typically lead to sudden anuria. Imaging is really important to see if there is a good flow into the kidney, and angiography may be important. While we obviously avoid contrast, this may be one issue, one indication for using small amounts of contrast to clinch the diagnosis if it cannot be easily diagnosed from ultrasound. And the reason is that surgical intervention is critical. It is really a surgical emergency. In many cases, if there is arterial obstruction, we'll not be able to resuscitate that kidney. Renal vein thrombosis can show up with thrombosis of the renal artery. That can lead to anuria, graft swelling. and reverse diastolic flow on ultrasound. Again, this is a surgical emergency. It is a little bit more forgiving, but often if you do not diagnose it and get the patient to the operating room very quickly, then it is not reversible. Ureteric obstruction, hydronephrosis may be subtle early on, and that is because the transplant ureter is short. You may not see a lot of hydronephrosis and still have obstruction. So remember when looking at the ultrasound to be aware of that. On the other hand, it is easy to overdiagnose hydronephrosis in a transplanted kidney because you will see some laxity of the tissues and some bulging, which may be mistaken for hydronephrosis. Obviously, if you see that, then the key is to decompress the kidney either with drain or depending on where the obstruction is, with a Foley catheter needs to be placed. Urinary leak, again, you should see something on the either in drain collection, you may see increased output from the drain collection. And then if you see that, then obviously you should send the collection for chemistry to see if the creatinine is elevated, as you would expect from urine, or is the same as the serum. But again, treatment is drain and stenting. Bleeding is another surgical emergency. You may see bleed, you may see something on imaging. If it is a retroperitoneal bleed, you may need to do a CT scan, it may not be picked up on ultrasound, and obviously the treatment is resuscitate the patient and treat the cause of the bleeding. And then lymphocele tends to occur later, and it is not necessarily such an emergency. If it is small, it can be observed. If you drain them, they can recur, and ultimately, it may be that they just disappear by themselves. If they're very large, they may need to be drained and fenestrated if symptomatic. So here's the first question. A 58-year-old man receives a deceased donor kidney transplant. Urine output is initially 150 mLs an hour. On post-operative day 1, he develops abrupt anuria, graft site pain and fullness and hypotension. The Foley catheter flushes freely and the bladder scan is empty. What is the single best next step? A, give 2 liters of crystalloid and reassess in 4 hours. B, obtain urgent transplant Doppler and notify the transplant surgery team. C, order a radionucleotide renogram. D, give pulse methylprednisone for presumed rejection. Or E, perform a percutaneous allograft biopsy. So I'll give a few seconds for people to give the answer. Yep, and I think everybody got this. Yes. Urgent transplant Doppler plus simultaneous surgery notification. Abrupt cessation of urine after initial function with a painful swollen graft is a vascular emergency until proven otherwise. I think that's very obvious. Fluid bolus alone may delay definitive evaluation in this situation. Acute rejection will not present this early unless it's hyperacute rejection, such as ABO incompatible transplants, or a very strongly cross-match positive anti-HLA antibody. Biopsy is not the first test, obviously, when vascular compromise is suspected. So, delayed graft function. Who is at risk? Well, there are a number of things that you need to take into account when you're thinking about delayed graft function. Think about the donor, you think about the recipient, prolonged ischemic time, whether there's hypertension within the recipient, whether a technical or hemodynamic events that may be contributing to that. Delayed graft function itself is a phenotype. It's not the actual cause of ongoing dysfunction. And many things can present as delayed graft function, current disease, can T-cell antibody-mediated rejection, vascular compromise, CNI toxicity, or it can be a combination of factors. It can be that you have a marginal kidney with a prolonged ischemic time that leads to delayed graft function, but that doesn't necessarily preclude that other things are going on. So if you see prolonged delayed graft function, you should really think about biopsying the kidney around day 7 to just make sure that there isn't a concurrent diagnosis that is also ongoing. So if we think about what are the donor risks specifically, donation after cardiac death, particularly if there's a prolonged warm ischemic time, if there is a high KDPI kidney or there is evidence of donor AKI, those kidneys are more likely to have delayed graft function. Patients with complicated anatomy or pediatric kidneys or donor-derived infection, that's something that often gets forgotten about. Donor-derived infection can lead to infection within the recipient, and often there's a delay in getting that information to the recipient team. In terms of preservation and reconditioning, a couple of important points. Hypothermic machine perfusion has been shown in some studies to reduce delayed graft function compared to static cold storage. It can also be useful for assessment by the surgeons as to whether they want to use that kidney. Normothermic perfusion is something that is just really we're starting to see more of. It restores warm oxygenated metabolism and enables functional testing in some cases. It hasn't really been shown to reduce delayed graft function, but we're still early in the days of normothermic perfusion, so it's important to differentiate the two. Normothermic perfusion is not so widely used, but is increasingly used, and there aren't any real definitive studies to show the benefit as of yet, although there are studies that are ongoing and some provisional data that's in the literature. So the second question, delayed graft function without recovery. A 46-year-old woman with a high CPRA of 98% receives a donation after cardiac death kidney. After a negative crossmatch, she requires dialysis on post-operative day 2, and requires dialysis on day 2 and 5. On day 7, her urine output is 300 mL per minute, and the creatinine is 8.1. Doppler shows patent vessels, no hydronephrosis, and the tacrolimus trough is therapeutic. What is the best single answer? Continue supportive care, because DGF is expected, increase tacrolimus target, perform an allograft biopsy, start empiric plasma exchange at IVIG, order donor-derived cell-free DNA instead of a biopsy. Give a few more seconds for people to answer. Okay, so great. I think most people got this. And yeah, it's perform an allograft biopsy. Remember, by day 7, you should really be starting to be concerned that there may be a coexisting problem. So even though delayed graft function might be expected in this patient, first of all, delayed graft function does not protect the kidney from having rejection, even though there is no function there. And once major vascular and obstructive causes are excluded, biopsy is the key test for unexplained dysfunction. All right, so let's talk a little bit about HCV positive and HBV positive donor kidneys. So hepatitis C positive kidneys can be used in hepatitis C negative recipients as long as they've consented to receive those organs. Same for hepatitis B. With hepatitis C, there is a good degree of literature that now shows that these can be used and nearly always work very well. There are a few important points to remember, though. Remember that the patient needs to have informed consent, that you need to be able to treat the patient immediately with antiviral therapy, and that if you do not know the genotype of the hepatitis C, you need to make sure that the patient has access to pan-genotypic therapy, which can be switched afterwards. The patient should be monitored carefully with HCV, RNA, LFTs, renal function, and modern series show a very high degree of response to antiviral therapy, and short-term outcomes have been excellent. With hepatitis B, many centers won't use hepatitis B kidneys unless there's really a special situation. Hepatitis B is a slightly different situation for a number of reasons. One is that the definition of what is hepatitis B needs to be clear. If you have a donor that has anti-hepatitis B core, is core positive, but surface antigen negative, that is usually low transmission kidney transplant recipients. It's important if an individual gets one of those kidneys that the patient gets vaccinated if they haven't already been, and they should be monitored, and a decision about prophylaxis should be made. The decision about prophylaxis will be made in the context of the recipient factors, such as whether they have surface antibody titer that is positive, whether they have previous HBV exposure, and the intensity of the immunosuppression as well. Now, when you have hepatitis B surface antigen positive or HBV DNA positive kidney, then you need to make sure, obviously, the patient's consented for that. They need close follow-up, and they will need therapy following transplant. So that is really a specialized circumstances, and it needs to be very clear that the patient has accepted that organ and that there is a benefit to transplanting that patient. And the other thing to remember is that in a higher risk donor, all recipients need to be tested for HIV, HBV, Hep C, and that 4 to 6 weeks following transplant. So in terms of immunosuppression, every center will have its own immunosuppression guidelines. And so what I've put up on this slide isn't really saying what is correct or incorrect at an individual center, but this is basically the thinking that goes behind stratifying the patient into a lower or higher risk patient. So a low risk patient would be a patient with no DSA, negative cross-match, first transplant, low CPRA, and they would be safe to get basiliximab. It's often preferred first-line induction therapy. The advantages are lower risk of infection and leukopenia, but it's obviously a less potent induction therapy. Some centers will use low-dose ATG for the low-risk patients, and it's perfectly acceptable. Patients with a higher CPRA or second transplant, or for whom you're considering steroid avoidance, that might be a good indication for giving recombinant ATG as induction therapy, basically for higher and moderately at-risk patients. And they have to be carefully monitored for leukopenia, thrombocytopenia, and also for increased risk of CMV, EBV, etc., and also for infusion reactions. So the other thing that you should be aware of is that there are consequences in terms of what type of induction therapy is given. Depending on the risk of the individual and the type of induction therapy they're given, it will potentially influence the likelihood of rejection. Rejection rates will be higher in patients who get basiliximab compared to ATG. It may influence the steroid withdrawal plan, although some centers do steroid withdrawal with basiliximab induction therapy. And also it may impact CNV and EBV surveillance, particularly in higher risk individuals. So maintenance immunosuppression is pretty standard. Most centers will use tacrolimus mycophenolate plus or minus steroids and early steroid withdrawal. There are common interactions with tacrolimus that you need to be aware of, which are listed at the bottom of the slide, but I will go through later on as well. When to convert to belatacept or mTOR inhibitors. So belatacept should be considered when there's evidence of CNI nephrotoxicity or TMA or intolerance or unstable exposure or to maintain long-term renal function. If it's a marginal kidney or there's concern that tacrolimus exposure in itself will be an increased risk to that individual. The requirements are the patient has to be seropositive, EBV seropositive, in order to be a candidate, and they has to have adherence and understand that they will need to go and get IV infusions every month. There is a trade-off. There is more early cellular rejection in some studies, and there is an increased risk of PTLD, but the risks are not hugely significant if you avoid giving it in EBV negative patients. Sirolimus and everolimus mTOR inhibitors can be used for CNI minimization or in select emergency or cancer context. It should be avoided when there's any proteinuria, delayed graft function, wound infection. Again, it causes cytopenia, edema, mouth ulcers, and pneumonitis. So that may be another contraindication for giving these drugs. Third case, 8 weeks after transplant, a 55-year-old asymptomatic recipient has a stable creatinine of 1.4. Surveillance plasma BK PCR levels rise from 2,800 to 15,000 copies per ml on the same assay for over 2 weeks. Tacrolimus trough 9.4, urinalysis ultrasound are unremarkable. Which is the single best initial management step? Start cidofovir, add leflunomide, reduce maintenance immunosuppression, stepwise repeat plasma BK PCR, give IVIG, give pulse methylprednisone. So can we get the responses up? So in the interest of time, I'm actually going to move on. So it's C, reduced maintenance immunosuppression, and I'm sure nearly everybody would have gotten this in repeat BK PCR. So allograft dysfunction. When you see allograft dysfunction, you really need to biopsy the patient if you've excluded other potential causes like anatomical obstruction, infection, etc. The time when you would consider this, if there's an increase in the creatinine or there are competing diagnoses and you're not sure whether this is CNI toxicity or TMA or rejection, when there is a signal that indicates that there may be an increased autoimmune response, by which I mean the DSA turning positive, or there's concerns about adherence, or if there are adjunctive biomarkers that may indicate that a biopsy is necessary, such as cell-free DNA, although cell-free DNA is not useful within the first month. There are now a number of other tests as well that may potentially indicate that there's graft dysfunction. These tests themselves cannot be used to diagnose rejection. but can lead to a biopsy, which may then tell you if there's rejection. T-cell mediated rejection is basically defined by its severity and staging by the Banff criteria. And there are different stages of severity from borderline to type 1A, type 1B, type 2A, type 2B, to type 3, which are just increasing levels of severity. What is important is that borderline rejection is not benign. So often people will treat borderline rejection as if it is rejection. That is something that you need to take into consideration very carefully. Usually 1A, 1B is treated with IV methylprednisone with optimization of baseline immunosuppression. 2A, 2B, or 3 would be an indication for lymphocyte depleting therapy, commonly ATG, in some cases alemtuzumab. Is important when you have severe T-cell mediated rejection that you carefully evaluate antibody mediated rejection. If you have steroid resistance, people will reach for lymphocyte depleting therapy such as ATG. If a patient doesn't respond, the patient often get a second course, or can be switched to alemtuzumab, which is what I do if they're not responding to the ATG. Antibody-mediated rejection, is a diagnosis that is made by taking into account histological allograft injury, so basically histology that's compatible with antibody-mediated rejection, whether there is T4D positivity, which is an indication of endothelial interaction, and whether there is DSA present, all in the context of worsening allograft dysfunction. There is no single FDA-approved standard antibody-mediated rejection therapy. It is center-dependent. Usually, the treatment is a combination of optimizing immunosuppression, treating any concurrent T-cell mediated rejection, and then plasmapheresis, IVIG, in some combination, steroids when necessary, and then rituximab or other adjunctive case-by-case therapies are considered. I'm going to skip over the next two slides. These are just basically descriptions of what antibody-mediated rejection are. Antibody-mediated rejection occurs at around 3 to 10% of renal transplants. It generally portends a worse prognosis in these patients. I said there is no one FDA-approved therapy. There are a number of different therapies that are being used both at individual centers and being tested in clinical trials. And then there are a number of also experimental potential treatments that are being reported as well. So moving on to other causes of graft dysfunction, post-transplant TMA and catastrophic antiphospholipid syndrome. It's important to act here before you've finalized a diagnosis in many cases. You need to recognize the syndrome. This is graft dysfunction, plus or minus hypertension, falling platelets with an elevated LDH, decreased haptoglobin, and presence of schistocytes. Hemolysis may be absent in kidney-limited TMA, and the biopsy may show acute TMA or microvascular injury. You don't have to wait for everything to be positive to suspect it. Workup needs to include CBC and smear, as I said, LDH, haptoglobin, bilirubin, reticulocytes, coagulation profile, creatinine urinalysis, tacrolimus levels, DSA, C4D biopsy in many cases, Adams 13 before plasma therapy, if possible, and complement history and genetics when we're considering a genetic cause for TMA. And then remember, there are multiple potential causes of this. and you need to treat by the mechanism. Is it related to CNI? Is it TTP? Is it complement-mediated TMA? Or is it catastrophic APS? So there are a number of recurrent diseases that are known to occur. Primary FSGS we've talked about, complement-mediated AHUS, IgA nephropathy, C3GN, MPGN, and anti-GBM in patients who've a history of Alport and then get transplanted and will develop an antibody against the GBM in the transplanted kidney. Just a couple of points. IgA nephropathy is very commonly reoccurs, is rarely severe. The course of the native IgA is probably the most important differentiator as to the likelihood of whether this would be severe or not. When it comes to C3GN or immune complex MPGN, think about what is the potential cause in terms of treatment. Question number 4. On post-transplant day 10, if we get a slide up, creatinine rises from 1.9 to 3.4, hemoglobin falls from 10.2 to 7.9, platelets from 210 to 55, LDH is high, haptoglobin is undetected, cystocytes are present, tacrolimus trough is 14, and the patient has a new anti-class 2 DSA. What is the single best next step? Treat as immune TTP with plasma exchange alone, give platelets and observe, evaluate TMA urgently, biopsy if safe, reduce or hold tacrolimus and treat the trigger, start eculizumab in every case, continue tacrolimus and give steroids only. Right, so the answer is C. So you have to evaluate it. Clearly, there are multiple potential different causes, and you have to run through the potential causes and then treat the cause. Question number 5. Nephrotic proteinuria in postoperative day 3. A 32-year-old man with kidney failure attributed to primary FSGS and has nephrotic syndrome before dialysis and no pathogenic podocyte gene variant. On postoperative day 3, creatinine is 1.2, edema develops, and serum albumin is 2.3 with a urinary PCR of 9 grams per gram. Doppler is normal. So what is the single next best step? Observe. This is expected. Ischemic tubular injury. Start an ACE inhibitor alone. Start prompt plasma exchange for presumed recurrence. Obtain biopsy and EM in parallel. Give pulse methylprednisone for T-cell mediated rejection. Convert tacrolimus to steroids. The answer is C, right? This is presumed primary FSGS and treated probably with plasma exchange. May or may not work, but this is really the best thing that we have. ACE inhibitors can be useful as an adjunct therapy later on. And obviously mTOR inhibitors may worsen proteinuria. So infection prevention by time after transplant. You should be familiar with this. This is just risk stratification based on timing post-transplant. Viral surveillance. BK polyomavirus. It's important to monitor patients in post-transplant year, typically month to month for the first 9 months, and then every 3 months for 2 years. CMV, DR positive into recipients, and D positive into recipient negative kidneys are at the highest risk and need 6 months of prophylaxis. Recipient positive, 3 months, and negative to negative may be treated with acyclovir or monitoring. EBV, PTLD risk, again, it's not actually, most centers will not do this unless it's a high risk patient. Maybe in pediatric cases, they would test this as well. When you see raising DNA for EBV, you should do clinical evaluation and immunosuppression reduction. HHV8 or Kaposi's sarcoma, there is increasing evidence that this is increasing. There was a recent paper that shows that the rate of donor transmission may be as high as 1 to 2% in the United States. We don't routinely test for this here. Some other countries will test for this. But again, the diagnosis is really based on suspicion post-transplant. Protocol biopsies, these are emerging surveillance tests. I will not go through those. Just to say that cell-free DNA is better at picking up antibody-mediated rejection than cellular rejection. But again, it is not a substitution for biopsy. Very quickly, something that is often overlooked is electrolyte bone mineral hematological problems. Hyperkalemia, treat the cause. Could be CNI, could be bactrim, can occur with acidosis or introduction of RAS blockade. Hyponatremia, you should assess the volume and tonicity, look for all the potential causes. Low magnesium and phosphate can be related to tacrolimus use, particularly high dose, high levels. Hypercalcemia, always think of the PTH. Use cinacalcet if there's an elevated PTH, there's persistent hypercalcemia, anemia and cytopenia. There are multiple causes, often drug-related. Important to check for hyperlipidemia. It's really part of good management, usually 2 to 3 months post-transplant. And then, if there is something that does not really fit with a diagnostic pattern, then you need to think about, is there something that you are missing? In the interest of time, I will not talk about this other than to say, do not assume that hyperglycemia post-transplant is irreversible and leads to post-transplant diabetes. You can often see this and it settles down with time. We are just really starting to use GLP-1s and SGLT2 inhibitors in the post-transplant setting, starting when the graft is functionally stable and based on indication. Don't forget about psychological and system issues within the patient. This is a question about post-transplant hyperglycemia. The point of this question is, if a patient has hyperglycemia, the treatment is to use insulin, right, and not try to manage patients without itch. There are a number of questions I've included. I didn't expect to go through these, but these are there, and these are just stems with really the important point about the stem and why these may be things that you should think about in terms of what you might expect to see in the board review. And then I will just go to the summary slide, which is basically, these are the take-home messages. You can read them. Basically, it's a summary of what we went over in the talk. There are some references if you have any interest in reading up about those topics. Thank you very much.